So, good afternoon, everyone. My name is Shivplara, consultant neurologist. So, I'm just going to talk few points about REM sleep behavior disorder. So, REM sleep behavior disorder, also known as RBD, comes under the category of parasomnias. The hallmark of this condition is absence of the normal physiological atonia during the REM stage of the sleep. So, due to this lack of atonia, patient presents with complex motor behavior with or without vocalization in the context of unpleasant dreams. So normally we call it as a dream enactment behavior. Studies has shown that usually patients present with motor behavior rather than a vocalization with previous study groups with RBD patients. So the recent criteria from the International Classification of Sleep Disorders suggests that if you want to definitely, for a definitive diagnosis of RBD, you need a video polysomnography. However, a single question screen asking the patients, do you have any symptoms suggestive of dream enactment, does have a good sensitivity of almost 93% and a specificity of 87% in diagnosing RPD comparing to polysomnography. Although it's not included in the diagnostic criteria, I think it's helpful clinically to diagnose patients with RBD. Coming to the prevalence of these conditions, most of the literature suggests less than 1%. However, they also comment that it's an underestimate for two reasons. One being patients doesn't come out with these complaints or symptoms when they come to the clinic with other neurological symptoms. And most of the time, this requires a polysomnography for a definitive diagnosis. So that can be a cause for the low prevalence of these conditions. It's mostly seen in older age group and mostly in male patients. So the male to female ratio is almost 9:1. And briefly coming to the pathophysiology, it's complex network of both biological, molecular, and neuroanatomical pathways involved. So there's no any single neurotransmitter or single anatomical region that has been suggested so far. Although initially it was thought it possibly it could be due to alpha synuclein deposition, purely based because it comes in the context of many neurodegenerative conditions with synucleinopathies. Uh, Although it's now shown that there are so many other neurotransmitters involved in this presentation. Now there's a small flow chart here on the left-hand side of the slide. So it's basically what happens in REMs in RPD patients is this is a normal flow chart to show how a REM stage of the sleep behaves. So the nuclei from the pons excite the neurons in the medulla, and then the neurons from the medulla transmit descending inhibitory projections to the spinal motor neuron, so resulting in the muscle atonia. So the initial response from the pons neurons send the triggering these neurons in the medulla and the inhibitory response to the spinal motor neurons, causing the patient to go into atonia during the REM stage of the sleep. But in patients with RPD, so this input from the pons, nuclei from the pons, is inhibited. So it could be a primary RBD. So there's no any structural lesions or any definitive cause for these symptoms, or it could be secondary due to a structural lesion, for example, stroke or a demyelinating plaque like multiple sclerosis in the brainstem can cause symptoms of REM stage behavior disorder. Interestingly, it is also noticed more frequently in patients who are on antidepressive medications like SSRIs or SNRIs. Uh, and paradoxically, it's also seen that sometimes antidepressive medications do help in REM stage behavior disorders because they shorten the REM stage of the sleep. So it can cause RBD or it can help in RBD. Also, lipophilic beta blockers like bisoprolol have been previously commented that it can cause RBD in patients. Coming to the treatment, so the level A evidence for the treatment is modifying the sleeping arrangements. So what it means is you just tell the patient that they have to avoid situations in their bedding or in their bedroom to avoid injuries like taking away the furnitures or asking the patient to sleep on the floor, etc. And we have also seen many number of patients coming to the clinic with head injuries or sleep-related injuries due to RBD. And it's very, very important to address the issue as well, because they can hurt the partners during this abnormal motor behavior. So sometimes we may have to ask the patient's partners to sleep in a separate room. So that's the primary modality of treatment or approaching the patients with RBD. However, there are some pharmaceutical agents that we normally try in these patients, although there's no significant evidence for that. So the first line usually recommended from the American Academy of Sleep Medicine is clonazepam, starting from a dose of zero point 0.5 milligrams, can go up to 4 milligrams. What clonazepam does is basically it reduces the intensity of the dream enacting behavior in general, and also it usually causes sleep in general population. So both these factors can help in RBD patients. If clonazepam is contraindicated for some situations or if not helpful, you can also give a trial of melatonin, starting with a dose of 3 milligrams and can go up to a dose of 12 milligrams per day. And normally advise taking 30 minutes before the bedtime. Melatonin usually helps by resetting the REM stage of the sleep, and also sometimes it can reduce the phasic tone of the atonia. So you can try melatonin for these patients. Sometimes you can try both combination of clonazepam and melatonin reduced doses, and that can be helpful to the patients. Okay, so just a few points of practice points. So it's always important to ask the partner about the symptom, because almost 50 to 75% of the patients do forget or don't remember or recall the unpleasant dreams or motor behavior. So you may miss the diagnosis, especially in the context of neurodegenerative conditions. Uh, video, some, uh, Video assisted polysomnography is essential to confirm the diagnosis and also to rule out other similar sleep disorders like a nocturnal awakening or nocturnal hallucinations, etc. And as we know that RBD is very important in the context of neurodegenerative conditions like silent telepathies, it's very, very important to follow up these patients for a number of years for early detection of conditions like MSA or Parkinson's disease or Lewy body dementia. And if you're seeing a patient in the context of MSA or a clinical question of MSA, and if the patient has Parkinsonism or a cerebellar syndrome, if the patient doesn't have any history of RBD or and it is confirmed by polysomnography, then it is less likely to be MSA. I think that's what I wanted to say. Thank you very much.